Hello and welcome to module 3 of advanced ECG course that's about complex ECGs. And here in this module we are going to talk about the pre-excitation syndromes, supraventricular tachycardias, ventricular tachycardias, and an exercise about wide complex tachycardia. So let's begin first with the pre-excitation syndrome, and we'll talk about the types of pre-excitation syndromes, mechanism of conduction through the accessory pathways, and ECG findings associated with pre-excitation mechanisms. So basically there are three types of pre-excitation syndromes. The most famous and well known is Wolff-Parkinson-White syndrome or WPW syndrome. The other one is Longenang-Levine syndrome or LGL syndrome, and the third syndrome which is unnamed syndrome involving Meheim's fibers. So these pre-excitation syndromes may cause both narrow and wide complex tachyarrhythmias. Before going through the pre-excitation mechanisms, let's review the normal conduction pathway in the heart. So electricity originates from the SA node, then it travels both the atria through the internodal fibers, and then it reaches to the AV node. This is a very important place because here the electricity stays for some time because it gives enough time to the atria to contract before the ventricles and we get the PR interval. Then the electricity moves fast through the through this bundle of his and right and left bundle branches to the Purkinje system. And on the ECG, we get the P wave, then the PR interval, then the big complex, which is Q, R, and S, and then the T wave when the ventricle relax. But what happened in WPW syndrome? In WPW syndrome, some humans are blessed with an accessory or additional pathway. This additional conduction pathway, which is known as bundle of Kent, this originates in the atrial tissue, then bypasses the AV node, either the right side or the left side, and then it's inserted into the non-Purkinje ventricular tissue. This is non-specialized conduction tissue, so it's inserted into the ventricles. So whenever anything is inserted into the ventricles, then it produces the excitation of the ventricles in abnormal way and the complexes becomes wide. So as the impulse bypasses the AV node and it's going through this bundle of Kent, so it causes the early depolarization of the ventricles, and once it reaches to the ventricle, it's not going to the Purkinje system. It started its contraction through the myocardium cells. So that's why the complexes might be wide. And you look at these three features of WPW syndromes or the triad of WPW syndromes, you will get the short PR interval because the impulse bypasses the AV node and reaches to the ventricles early. So that's why we get a very short PR interval. Then the impulse attaches and then this impulse reaches to the non-specialized tissue of the myocardium, that is the muscle of the myocardium. So we will get the wide coarse complexes, or there is a notch which is called the delta wave. It's because of the early depolarization of the ventricles, and then this impulse combines with the normal impulse which is coming through the AV node, and then we'll get the big Courus complex. So WPW syndrome has three components: of wide Courus complex, especially at the base. There is a short PR interval and there is a delta wave, that is slurring of the upstroke of the Courus complex. So these are your WPW syndromes. The gentleman in black dress is your White, then Parkinson White. WBW syndrome has two varieties, the type A and the type B. It depends upon the which side of the heart the bundle of Kent is present. In type A, you get the dominant R wave in the lead V1. In type B, you will get the dominant S waves in the lead V1 and V2. In type A, you will get the prominent R in V1 and V2. And there is early activation of the left ventricles, and you will see the delta wave. You can differentiate it with right bundle branch block, right ventricular hypertrophy, and posterior wall myocardial infarctions. These are the differential diagnoses of type A WBW syndrome. Look at this one and just look at the V1 and V2, and we get the tall R wave in V1 and V2. But if you carefully notice, the PR interval is short and there is slurring of the R wave. If you see, there is slurring of the upstroke of the R wave. So this is your WBW syndrome type A. In type B WBW syndromes, you will get the negative Kurus complexes in the lead V1 and V2, and there will be prominent S wave in the right precardial leads. And this happens because of early activation of the lateral aspect of the right ventricle, and you will see the delta waves as well. The differential diagnosis for the type B WBW syndromes includes the left bundle branch block and anteroseptal myocardial infarction. Look at this ECG. So look at V1 and V2. At the first look, it looks like a left bundle branch block. But if you look carefully, you may find the small P wave here and very short PR interval, and there is slurring of the R wave. So this is again WBW syndrome, but the type B. It's very important to remember that certain drugs you should avoid in WBW syndrome, and especially the drugs B, C, and D, beta blockers, calcium channel blockers, and digoxin. These drugs slow the conduction at the AV node. So what happens if a conduction is slowed at the AV node? Then the impulse, which is already following equally through the bundle of Kent, it becomes more faster and produces more lethal tachyarrhythmias. So that's why it's advisable that don't use the beta blockers, calcium channel blockers, and digoxin in WBW syndrome patients. The other syndrome, which is because of the pre-excitation mechanism, is LGL syndrome. And here again there is accessory pathway that originates in the atrial tissue and it bypasses the AV node. But this time it inserts into Purkinje ventricular tissues. So that's why this will result in short PR interval but no delta wave, because it's going to the normal conduction system. So that's why you will not get the delta wave, although the PR interval will be short. So the fibers are the accessory pathway used in the LGL syndrome is called James fibers. So you will get the short PR interval only without delta waves. Look at this ECG. This is a 50-year-old man with bouts of tachycardia. And you will appreciate here the short PR interval, but no delta waves, no slurring of the initial R wave. So this might be might be the LGL syndrome. A bundle of James are involved here. The third mechanism of accessory pathways or pre-excitations is the Meheim types of pre-excitation syndrome. Here, these fibers originate in the AV node. So from the AV node, from here, and insert into the non-Purkinje ventricular tissues. So what will happen? You will get the normal PR interval, because the normal impulse originates from the SA node and goes to the AV node. It's fine. You will get the normal PR interval. But here some of the current goes through the accessory pathways, which is the Meheim types of the fibers, and this causes the pre-excitation of the ventricle, because it's going to the non-Purkinje system, to the myocardial tissues. So you will get the delta wave and a little bit wider Quercus complexes. So in Meheim fibers, you will get the normal PR interval as well as you will get the delta waves. So here, if you look here, the normal PR interval and wide Quercus complexes. So this might be a Meheim type of pre-excitation syndrome. Normal PR and delta wave. So in summary, pre-excitation syndromes are three types: WPW syndrome, LGL syndrome, and Meheim fibers. The fibers involved, or the accessory pathway involved, is called bundle of Kent in WPW syndrome, James fibers in LGL syndromes, and Meheim fibers in the third syndrome. In case of WPW syndrome, you will get the short PR interval with delta wave. But in James fibers, you will get short PR interval but without delta wave. And in third variety, Meheim's fibers, you will get the normal PR interval with delta wave. So this classification is purely an academic classification, because in real life it's very hard to differentiate between these three types. And the LGL and Meheim fibers, these ECGs are very uncommon. But WPW syndrome, these ECG you will commonly encounter in your clinical practice, and you will often see these ECGs, and most of the time you will come across to find the ECG with WPW syndrome. Now, after learning the different pre-excitation mechanisms, now this is the time to review the supraventricular tachycardias. A few of the mechanisms we have already learned in the step 2 of the module 2 in the arrhythmia section, and here we'll further enhance our knowledge about the tachyarrhythmias. So let's begin with the supraventricular tachycardias, and here we are going to talk about the classification of supraventricular tachycardias, mechanism of re-entrant phenomena, and ECG findings in supraventricular tachycardias. It's very important to note the definition of SVT. It's a general term that describes the tachycardias arising from the atria or the AV node, excluding the sinus tachycardia. So it means any tachyarrhythmias which originate above the ventricles is supraventricular tachycardia, except the sinus tachycardia. Exact cause not always obvious. So supraventricular tachycardia can be narrow complex, can be wide complex. Narrow complex are regular and irregular. Irregular are atrioventricular nodal reentrant tachycardia, which is also known as classical SVT. It may be atrial flutter with fixed block and orthodromic atrioventricular reentrant tachycardia of WPW syndrome, and we will learn soon about these different SVTs. Irregular narrow complex SVTs includes the atrial fibrillation, atrial flutter with variable blocks, and multifocal atrial tachycardia. SVT can be wide complex, especially if the arrhythmia originates from the atria, but when the impulse moves down to the ventricle, it may get blocked in one of the bundle branches, right or left, and the supraventricular tachyarrhythmia may becomes the wide. Similarly, if the impulse bypasses the AV node and goes through the accessory pathways to the myocardial tissue, the impulse may get wide, as in WPW syndrome. Although the arrhythmias originates from the atria, but on the way to the ventricles, it may get widened due to the blockage or through the alternate route. So SVT can be narrow complex, can be wide complex. Okay, so again look. First, we will talk the narrow and regular supraventricular tachycardias, and three main mechanisms are involved. The one is the atrioventricular nodal reentrant tachycardia. Here, the impulse originates from the atria and then it moves around the AV node. That's it's called atrioventricular nodal reentrant tachycardia. The second mechanism is the orthodromic atrioventricular reentrant tachycardia. Here, the impulse originates from the atria, then goes through the AV node and normal conduction system, causes the excitation of the ventricles, then comes back and it finds an accessory pathway, and then it makes a loop and re-enter the atria again, and from the atria to the ventricles again. So re-entrant phenomena. This is called orthodromic atrioventricular re-entrant mechanism. And the third is atrial flutter with fixed block. So the impulse moves 2 or 3 times in the atria before going to the ventricles. The most commonly the 2-into-1 variety, where 2 times the impulse moves in the atria before going to the ventricle. So atrial flutter with fixed block. So let's review again the atrial flutter with fixed conduction. So whenever you see an ECG in the emergency department where the heart rate is approximately 150 beats per minute and without obvious reason of tachycardia like blood loss or fluid loss, so always consider atrial flutter with 2-into-1 conduction. So look here, the differential diagnosis here is atrial flutter with 2-into-1 conduction. So impulse moves 1-2 times in the atria and then goes down to the ventricles, and we'll get the heart rate or ventricular rate of 150. If it moves 3 times, we'll get 3-into-1 conduction. So it means 300 heart rate, ventricular rate, and you may get the 3 flutter waves. If it moves 4 times, you will get the 70 heart rate and 4 flutter waves, and then you may get the sawtooth pattern. But here at 150 heart rate, it's difficult to get the sawtooth pattern because it's only, you will see the 2 notches here, the flutter wave. So this is your atrial flutter with 2-into-1 conduction. So look at this ECG. Again, this is a 50-year-old patient who comes to the emergency department with sudden onset of palpitation and heart rate. Again, look at 150 and 150 heart rate, around 150 heart rate, always keep a differential diagnosis of atrial flutter with 2-into-1 conduction, and flutter waves are seen best in lead V1, lead 2 here in this ECG, lead 3. So some notches are seen. These are your flutter waves. So another mechanism of supraventricular tachycardias that are narrow complex is atrioventricular nodal reentrant tachycardia. And this type of tachycardia accounts for more than 70% cases of paroxysmal supraventricular tachycardia. It's also known as SVT, classical SVT, where the heart rate will be from 140 till 250 beats per minute, and chorus complexes shall be narrow and no P waves. Look at this ECG. There is a P, chorus complex, and T. So it means these impulses, the 1, 2, 3, and 4 are coming from the sinus node. But the impulse fifth is a different shape of P wave, and this is not coming from the sinus node. It's coming from some ectopic focus in the atria, and then this ectopic focus is strong enough, it took over from the sinus node and started producing its own arrhythmia, which is a narrow complex without P wave, and heart rate is almost 150, 160. So this is your SVT. So this is a paroxysmal SVT, the paroxysm of the normal complex followed by the ectopic beats and then the SVT. So this atrioventricular nodal reentrant tachycardia is almost always initiated by premature atrial complexes. Let's discuss the mechanism of reentrant phenomena or atrioventricular nodal reentrant phenomena. So AV node is blessed with two types of the fibers: the fast pathway, which is known as the beta fibers or beta pathway, and the slow fibers, which is known as the alpha pathway or alpha fibers. So impulse normally originates from the atria and then it goes through the fast pathway or beta fibers and before going to the ventricles. So this is the normal pathway. But there is a characteristics of fast pathway also, that they have the long refractory period. The refractory period means the amount of the time an excitable membrane takes to be ready before the next impulse generates. So it's just taken as the rabbit. So what happens, the rabbit moves very fast, and then before moving further fast, it goes into the sleeping mode and stays here in sleeping mode. On the other hand, the alpha fibers, they are slow. So what happens, the rabbit is sleeping, the fast pathways are in the refractory period, means they are in the sleeping mode. So here the impulse originates again, but from the ectopic focus, and it's carried out by atratile. Because it's a slow impulse, goes slow, but it has a very short refractory period, because it will take a small nap and then it starts again and it goes through in the retrograde fashion, and then enter in a very critical phase where the fast pathway or the rabbit is still sleeping. By the time it reaches close to the rabbit, then the rabbit starts following it, and then a loop is formed around the AV node, which is called atrioventricular nodal reentrant phenomena. So in simple words, so the impulse from the ectopic focus, it enters through the slow pathway, and in the retrograde fashion it goes back towards towards this area where the fast pathways or beta fibers are in the refractory period, and once the refractory period is over, they start making a loop around the AV node. So again, atrioventricular nodal reentrant tachycardia, it involves two pathways within the AV node: the fast pathway and slow pathway. A fast pathway conducts the impulse rapidly, but it has a long refractory period and slow recovery time. On the other hand, the slow pathway or the alpha fibers, they conduct impulse slowly, but it has a short refractory period and fast recovery time. So because of these characteristics, a loop is created around the AV node. Okay, and it keeps on producing a narrow complex tachycardia. Look at this ECG. Just look at the bottom of this ECG strip. This is tachycardia. It's a narrow complex, no P wave. So this is your supraventricular tachycardia, and most commonly it's atrioventricular nodal reentrant tachycardia. Again, one more mechanism of narrow complex supraventricular tachycardia is atrioventricular reentrant tachycardia. So pre-excitation dysrhythmias can be produced by two mechanisms, or of two types: orthodromic atrioventricular reentrant tachycardia, which is a bit common, and there is antidromic atrioventricular reentrant tachycardia, slightly uncommon. And let's review the mechanisms. In case of orthodromic atrioventricular reentrant tachycardia. A premature atrial complex originates from the atria and it goes through the AV node and then follows the normal Purkinje fibers and to the ventricles, and then it's in the retrograde fashion. It passes through the accessory pathways and comes back to the atria and makes a loop. This impulse circles repeatedly and results in narrow complex tachycardia. As this impulse is following a normal conduction pathway, so there will be no delta waves in case of orthodromic atrioventricular reentrant tachycardia. Cavernous complexes shall be narrow because it's following the normal conduction pathway, and the heart rate will be 140 to 250 beats per minute. So the conduction is antegrade through the AV node, and then once it's finished, then in a retrograde fashion through the accessory pathway it makes a loop. Look at this ECG and see at the bottom the rhythm strip. Again, this is a tachycardia. It's a narrow complex, no P wave, so this is supraventricular tachycardia, and this may be orthodromic atrioventricular reentrant tachycardia. But orthodromic atrioventricular reentrant tachycardia is very difficult to differentiate from atrioventricular nodal reentrant tachycardia on ECG. To differentiate these two different mechanisms, we have to get the consultation with the electrophysiologist, and it needs EP studies. Okay, so pre-excitation syndromes or pre-excitation mechanism can produce another type of tachyarrhythmia, which is called antidromic atrioventricular reentrant tachycardia. Here the impulse originates again from the atria, but instead of going through the AV node, some of the impulses follow the accessory pathway, this bundle of Kent, and it goes to the non-specialized myocardium. As it's going to the non-specialized myocardium, it's expected to produce the wide Kurus complexes. Then the impulse travels in the retrograde fashion via the AV node again and make a loop, make a circle. This is antidromic atrioventricular reentrant tachycardia. But the important thing is, although this impulse is generated from the atria, but the ECG complexes are wide because the impulse goes through the accessory pathways and then in the ventricles it causes the excitation of the non-specialized myocardial tissue and then goes back and makes a loop. So you will get the wide complexes tachycardia, and this is difficult to differentiate from the ventricular tachycardia. So now we'll talk about the wide complex tachycardias. And wide complex tachycardia is the most tricky ECG tracing, and it's very difficult to differentiate a different type of tachyarrhythmias. But let's see. In this topic, we are going to cover the classification of wide complex tachycardia. We'll talk about the wide complex tachycardia of supraventricular origin, and then wide complex tachycardia of ventricular origin, and then we will apply a diagnostic approach to diagnose a wide complex tachycardia. Again, wide complex tachycardia can be supraventricular in origin or can be in ventricular in origin, and sometimes you don't know from where it's coming. Is it the source supraventricular or ventricular, it's not obvious. So supraventricular tachycardias, which may appear as wide complex tachycardia, can be regular or irregular. Regular is SVT with apparent conduction or with bundle branch block, or SVT with accessory pathway or WBW syndrome. Irregular are atrial fibrillation or atrial flutter with apparent conduction or with accessory pathway. On the other hand, the wide complex tachyarrhythmias can originate from the ventricles, in which case they may be regular or irregular. Regular are monomorphic ventricular tachycardias and irregular are polymorphic ventricular tachycardias or torsade de Pons. And sometimes, as I said, it's difficult to differentiate the source of origin of wide complex tachycardia. So two main mechanisms of wide complex tachycardia of supraventricular origin are accessory pathway or pre-excitation syndromes or the aberrancy as with or the bundle branch blocks, apparent conduction. So first, atrial tachycardia and accessory pathway. Sometimes the impulse originates from the atria, then it follows accessory pathways and reaches to the myocardium. As this is the non-specialized conduction area, so the chorus complexus becomes wide as it travels across the ventricles, and then it goes back in the retrograde fashion to the AV node and then makes a loop. So look at this ECG at the bottom of the ECG strip. This looks like wide complex tachycardia. So differential diagnosis is here. It may be supraventricular region or maybe ventricular in origin. If it's supraventricular in origin, it may be SVT or maybe it's atrial fibrillation. If you see, it's the same shapes. So no P wave, but these are the wide complexes, but they are irregular. So maybe atrial fibrillation. Okay, and if you see the morphology, this is a right bundle branch block pattern. So this may be atrial fibrillation with the right bundle branch block, or maybe this is SVT with right bundle branch block. On the other hand, this may be a monomorphic ventricular tachycardia, as the shapes are same and in between these may be capture beats, or maybe this is polymorphic ventricular tachycardia. So you have multiple differential diagnoses for this one. So this may be ventricular tachycardia, atrial fibrillation with bundle branch block or WBW syndrome, or SVT with bundle branch block or WBW syndrome. So this patient comes to the emergency department with palpitation, and he was sweaty, chest discomfort, and blood pressure was 80/50. You decided that this patient needs cardioversion. So patient was cardioverted successfully, and this is the ECG after the cardioversion. So the patient has R wave in V1 and V2, looks like right bundle branch block pattern. But if you look carefully, is a short PR interval slurring of the delta wave. So this is your type A WBW syndrome. Another mechanism that can produce the wide complex tachycardias are the impulse originates from the atria and gets blocked on the way to the ventricle. Like for example, one of the SVT, it originates from the atria and then it goes down to the bundle office and right and left bundle branches. On the way to the ventricle, if it's blocked at one of the bundle branch, like here in this example, the right bundle branch, so you will get the wide course complexes because the impulse will go to the one side, then from here goes back to the other ventricle and causes the ventricles to becomes wide. See here, The impulse can be blocked at the right bundle branch or can be blocked at the left bundle branch, and we call them right bundle branch block or left bundle branch block. Okay, so impulse from the atria goes to the ventricle, and on the way, if it's blocked by the right bundle branch, so we get the RSR pattern or quite wide Kurtz complexes in the V1. If it's blocked on the left side, left bundle branch, we get the Kurtz complexes that will be down and wide in V1. Look at this ECG and focus on the bottom, the rhythm strip. This looks like wide complex tachycardia. And if we have only this one, we may say it's ventricular tachycardia. But if you look carefully, the other part of the ECG, so this looks like the left bundle branch block pattern. So this may be your SVT with the left bundle branch block. Look at this ECG. In the rhythm strip, it looks like tachycardia. If you keep an eye on the whole of ECG, it looks like wide complex tachycardia. The rate is almost 150. So 150 heart rate. Okay, again, the differential diagnosis comes to your mind will be SVT or atrial flutter with 2:1 conduction. So these are the notches. So this is your atrial flutter with left bundle branch block. You see the pattern, left bundle branch block. Look at this ECG. Again, this is wide complex tachycardia, but this seems to be irregular. You see the RR interval is variable. So this difficult to get SVT with this irregularity. So probably this is atrial fibrillation with left bundle branch block. We have the findings of the left bundle branch block. Okay, so now we will talk about the wide complex tachycardia that originates from the ventricles. So if the pacemaker is in the ventricles, this ectopic focus is in the ventricle, it may fire very fast and produce the wide complex tachycardia. If one focus, it produces the monomorphic ventricular tachycardia. If many, it may produce the polymorphic ventricular tachycardia. Look at this ECG and look at the rhythm strip. This is a wide complex tachycardia. So this is your monomorphic wide complex tachycardia. It's a 57-year-old woman who presents to the emergency department with dizziness. Initially, her ECG is normal, but her symptoms return and her ECG is as follows. So this is the ECG of this symptomatic patient. If you see this bottom rhythm strip, this is a wide complex tachycardia, but in between there are few label letters. This P stands for the P wave, C stands for the capture beat, and F stands for the Fuin beats. So I hope you have heard these names P, C, and F somewhere. So what do you understand by the absent RS in the chest leads? What is atrioventricular dissociation? What is capture beat and Fuin beat? So the question is, how do they help or hurt you in your ECG interpretation in case of wide complex tachycardia? Are these terminology helpful in making the diagnosis or not? So let's talk first about what is RS pattern in ECG. So in RS means some of the ECG complexes have a positive portion, which is R, and some of the portion is negative, which is S. If you draw a isoelectric line, so the area above the isoelectric line, which is R wave, and below the isoelectric line is the S wave. So this is RS. This is present in the normal ECGs. Okay, but if this RS is lost, this is in favor of ventricular tachycardia. This loss of RS may be positive or negative concordance, means all the Gauss complexes are either positive direction or the negative direction, but the RS is lost. So this is extremely important. If you get a wide complex tachycardia with the loss of RS, your diagnosis most probably is ventricular tachycardia, because the absence of any RS complex in the chest leads is 100% specific for ventricular tachycardia, but maybe insensitive. If you don't get, if you are doubtful about the RS pattern, loss of RS pattern, then look at the width of the Gauss complexes, especially R2S width. If it's more than 0.10 second in any chest leads, this is your Brugada sign. If you get this one, R2S width more than 0.10, it's again in favor of ventricular tachycardia. So the area between the R and start of the R and start of the S wave, if this area is more than 2.5 small boxes or 0.10 second, this is in favor of ventricular tachycardia. This is called Brugada's sign, R2S width. Additionally, if you get a P wave seen throughout the ECG and it's not related to the Gauss complexes, again, this is in favor of ventricular tachycardia, and it's called atrioventricular dissociations. Means atria are producing their own current in form of P waves in between, but the ventricle are producing their wide Gauss complexes by their own, and it's quite fast. So these P waves are buried somewhere. But if you see, this is obviously a feature of ventricular tachycardia. Sometimes you will see few more beats in between the wide Gauss complexes. If a normal beat combines with the abnormal complexes, it's called Fian beat. Or if a beat is captured, is seen between two abnormal wide complexes, this is a capture beat. If you see a Fian beat or a capture beat, again, this is in favor of ventricular tachycardia. So just reviewing these few steps, let's go through a diagnostic approach about the wide complex tachycardia. And here the first step is, if you see the wide complex tachycardia, you have to make sure that this is regular or irregular. If it's regular, the causes are SVT with bundle branch block or with WBW syndrome or monomorphic ventricular tachycardia. But if it's irregular, it's atrial flutter or atrial fibrillation with bundle branch block or WBW syndrome, or it's polymorphic ventricular tachycardia or torsade de pointes. But the issue is with the irregular wide complex tachycardias. Okay, and this is the most difficult ECG tracing to interpret. So Brugada's algorithm, we are soon going to see, is a useful tool to diagnose regular wide complex tachycardia. It's very sensitive and specific. So this is your Brugada's algorithm, and it's your step 2 of the ECG interpretation or wide complex tachycardia interpretation. If you see a regular wide complex tachycardia, immediately look at the chest leads and see if there is absent RS in the chest leads. If the answer is yes, this is your wide complex tachycardia. Story is over. Not obvious, go to the next step. R2S width, if it's more than 0.10 second in any chest leads, if the answer is yes, it's your wide complex tachycardia. Still not sure? Try to find atrioventricular dissociations like P wave independent of the Gauss complexes, Fian beats, capture beats. If you get any of these, again, this is in favor of ventricular tachycardia. Still, you are not convinced, look at the morphology of the Gauss complexes in the chest leads. Especially look for the pattern, whether this is a right bundle branch pattern or left bundle branch block pattern. This is the normal pattern of the right bundle branch. That is, V1 is positive and V6 is also positive. Okay, so V1 has either RSR pattern or wide R wave, and V6 has is also positive with the deep S wave. If this pattern is present in case of wide complex tachycardia, that's the normal pattern. If it persists, it's more in favor of supraventricular tachycardia. But if this pattern is lost, V1 stays positive but V6 becomes negative, then such wide complex tachycardia, the source probably is ventricular tachycardia. And you will get the positive Curis complexes in V1 and negative Curis complexes in V6. Curis complexes becomes wide, like 4 to 5 small boxes. There may be associated right axis deviation. And additionally in V1, usually we get the small r, then s, and then the big R. Small r, small s, and big R. But if it's ventricular tachycardia, the initial R will be tall R wave, small s, and then small r. Capital R or SR. If the morphology is left bundle branch block pattern, look at the V1 and V2. If the normal pattern persists, this wide complex tachycardia is most likely a supraventricular tachycardia, and the normal pattern is that you will get the negative wide Curis complex in V1 and positive wide Curis complexes in V6 with a notch. But if you get a wide Curis complexes in V1 and also the negative wide Curis complexes in the V6 and with maybe some Q wave, so this is more in favor of ventricular tachycardia. So in presence of left bundle branch block pattern, the following features favor the ventricular tachycardia: negative Curis complexes in V1, negative Curis complexes in V6. Curis complexes are wide, more than 4 small boxes. There may be very bizarre axis deviation, and V6 just focus. If you get even smallest Q wave, this is more in favor of ventricular tachycardia. Let's apply this Brugada's algorithm and the steps we have learned in this module in an exercise which is about the wide complex tachycardia. So diagnosing wide complex tachycardia at times proves a big headache. So, but if we apply these steps, it may become a bit easy to diagnose, to differentiate wide complex tachycardia of supraventricular region or ventricular region. So, first step we'll see, is it wide complex tachycardia or not? Then regularity, regular or irregular. If it's regular, we'll follow the next 5 steps. If it's irregular, then the Brugada's algorithm is not applicable. If it's regular, then we'll go to see loss of RS, Brugada's sign, atrioventricular dissociation, capture Fian beats, and Curis morphology. So let's see, this is the first ECG, and look carefully the whole ECG and especially the rhythm strip. Is it wide complex tachycardia? So answer is yes. Regular or irregular? It's regular. Look at the chest leads, and is there loss of RS? Answer is yes. So this is our ventricular tachycardia. But let's continue. Brugada sign. Yes. Atrioventricular dissociation. It's difficult to find any P waves or any capture or Fian beats. And right bundle and morphology of the Curis complexes in lead V1, V2 is the right bundle branch block pattern. So our interpretation, very straightforward. This is ventricular tachycardia. Look at this ECG again, and is it wide complexes or narrow complexes tachycardia? It's wide complex tachycardia. So your answer is yes. Regular or irregular? Again, this is mostly regular. Loss of RS, look at the chest leads. So mostly RS is lost. Brugada sign is also positive, very wide. So any capture or Fian beads, difficult to find. And morphology of the Quercus complexes is right bundle branch block pattern. But up to the point 3 or 4, we have already diagnosed that this is ventricular tachycardia, monomorphic ventricular tachycardia. Look at this ECG. Is it wide complex tachycardia? Yes or no? So if you just focus on the rhythm strip, maybe it's not obvious, but if you look at the other parts of the ECG, yes, it's a wide complex tachycardia. It's irregular. Loss of RS, no. There is RS pattern is intact. Brugada sign, yes, may be seen. So up to now we are doubtful whether it's a ventricular tachycardia, supraventricular tachycardia. Let's see any atrioventricular dissociation. It's difficult to find P waves or capture beats or Fian beats. But if you look at the RS QRS morphology in lead V1 and V6, so it's lost. Normal right bundle branch pattern is lost. V1 is positive and V6 is negative. So this is in favor of ventricular tachycardia. Also the initial R is capital, then small r, then small s, and then small r. So R capital, small r, small s, RS pattern. This is favor of ventricular tachycardia. Difficult. Okay, let's see again another. It's a wide complex tachycardia. Answer yes or no? Yes. Regular or irregular? This is regular. Loss of RS? Yes, in most of the leads. Brugada sign? Yes. And you see these are the special notches in the Quercus complexes. This is called Jefferson sign. This is also in favor of ventricular tachycardia. You get the any AV dissociation, capture beat, and Fian beats, difficult. And pattern is right bundle branch block pattern. It's probably not applicable to this ECG. So our interpretation in this ECG is ventricular tachycardia. Look at this one. Is it wide complex tachycardia or narrow complex? So it's doubtful. It's not wide complex. If you see the rhythm strip and in many other places, but some places you see it's wide. So that's why it's a bit doubtful. Regular or irregular? So it looks irregular. You see the RR interval is variable. So here we are not going to apply the Brugada's algorithm and we'll omit these steps. Loss of RS, Brugada signs, capture beats, Fian beats, P waves. But look at the pattern of QRS morphology in V1 and V6. This is right bundle branch block pattern. So this looks like that this is irregular tachycardia, narrow complexes, and some places it's a wide complexes. So we will say if we'll just focus the V1, it's a wide complex tachycardia, irregular, no P wave with right bundle branch block. So this is your atrial fibrillation with right bundle branch block. Again, look at this ECG. Is it wide complexes or narrow complexes? Some part of the ECG, if you look at the rhythm strip 2, it looks narrow complexes. But if you look at the V1, it's a wide complex. So it's a doubtful. But let's take it as a wide complex tachycardia if we'll just focus on the V1. Regular or irregular? This looks like regular. If it's a regular and wide complex, let's apply it to Brugada's algorithm. Loss of RS? No. Brugada sign? No. Any atrioventricular dissociation, capture beats, Fian beats? No. And bundle branch block morphology, it's a right bundle branch block. So this is a regular narrow complex tachycardia, or maybe wide complex tachycardia with the right bundle branch block. So this is your SVT with the right bundle branch block. So SVT coming from the artery and block on its way to the ventricle at the right bundle branch. So that's why it becomes bit widened in the V1, V2, some of the chest leads. Look at this ECG. Is it a wide complex tachycardia or narrow complex? So the answer is wide complex. Yes. Regular or irregular? You see the RR interval is variable. So this is irregular. So we are not going to apply Brugada's algorithm. So we'll omit this loss of RS, Brugada signs, AV dissociation, capture phi and beats. But look at the morphology of the bundle branch block pattern. So here is looks like negative S wave, negative Curtis complexes in V1. Okay, so irregular, and this looks like the left bundle branch block pattern. So irregular wide complex tachycardia with left bundle branch block. So this may be atrial fibrillation with left bundle branch block. Now look at this one. It's a wide complex tachycardia, no P wave, and it's regular. So it's a wide complex tachycardia, yes, and it's regular. Loss of RS, no, these are intact, no loss of RS. Brugada signs, maybe some places seen, but generally it's not. AV dissociation, no. No capture, no phi and beats. Look at the morphology. It's the left bundle branch block pattern. So this is your SVT with left bundle branch block. So there are few signs which favor the ventricular tachycardia, and this comes in your board exams as the signs favoring the ventricular tachycardia. So Curtis complexes are broad, usually more than 4 small boxes. You may see the phi and beats, capture beats, atrioventricular dissociation, and there may be positive or negative concordance. You will see the Jefferson signs that these are the few notches present throughout the white Curtis complexes, and you may get the Brugada signs, that is the R2S width more than 0.10 second, and you may get very bizarre and extreme axis deviation, and there is absence of typical right bundle branch block or left bundle branch block morphology. If these signs are available, this is more in favor of ventricular tachycardia. But still, at time, it causes a lot of confusion because my interpretation may be different than your interpretation. So look at this ECG. If you just look at the rhythm strip, it looks like narrow complex tachycardia. But if you look at the ECG as a whole, especially the chest leads, this may be wide complex tachycardia, and it's regular. Loss of RS, no. So this is not in favor of ventricular tachycardia. But look at Brugada signs. This is positive in many areas. Atrioventricular dissociation, you may see these P waves in between. Oh my God. And there is a short PR interval. Capture phi and beats, no. And what's the morphology? It's right bundle branch block pattern. And the initial R is taller than what you see in the normal right bundle branch block. So some points it looks like ventricular tachycardia, and other points it looks like SVT with aberrant conduction. It's narrow complex tachycardias. So it's difficult to differentiate. So in such cases, we say this is wide complex tachycardia, but uncertain origin. Look at this one again. This is a wide complex tachycardia. Yes. This is irregular. So we are not going to apply the Brugada's algorithm. So loss of RS and Brugada signs will omit these steps, AV dissociation, capture phi and beats. But look at the morphology. This is a right bundle branch block pattern. So this may be atrial fibrillation with right bundle branch block or uncertain type, because this may be polymorphic ventricular tachycardia, or this may be ventricular tachycardia, or even if you see here are the capture beats and these are the P waves. Okay, so maybe capture beat, or maybe this is a P with the short PR intervals and slurring of the delta wave. So this is maybe WBW syndrome, which is causing this is wide complex tachycardia. So this is really uncertain type. So wide complex tachycardia is same as counting the number of buoys here. So safest option is to regard a wide complex tachycardia of uncertain origin as ventricular tachycardia. If a ventricular tachycardia is wrongly treated as SVT, the consequences may be extremely serious. And giving verapamil to a patient with ventricular tachycardia may result in hypotension, acceleration of the tachycardia, and even death. So here question is, the wide complex tachycardia we see in our practice, are all wide complex tachycardia cardiac in origin? Look at this ECG. It's a 19-year-old girl presents with palpitations and feeling unwell. Past history not significant and blood pressure is 125/60. So you see clinically this patient seems to be stable, and if we look at the ECG, it's a wide complex tachycardia. And we are not sure that this is ventricular or supraventricular tachycardia. But as we have discussed, that take the uncertain type of wide complex tachycardia as ventricular in origin. So we take it as ventricular tachycardia. So the question is, will you follow ACLS protocol? In ACLS algorithm, if we get a wide complex tachycardia and the patient is hemodynamically stable, we follow the algorithm and we give the drugs. And the most common drug we use to give for wide complex tachycardia or ventricular tachycardia where the patient is hemodynamically stable is amiodarone. So one of the doctor, she found that the patient is stable, and she treated this patient with IV amiodarone as per ACLS protocol. But this patient went to the bradycardia and then asystole and was unable to be resuscitated. So why? So the answer is, you have to consider some other causes of wide complex tachycardia of non-cardiac in origin as well. This patient had a ventricular tachycardia as our initial assumption, but in fact it was not the wide complex tachycardia, it was the hyperkalemia where patient's potassium level is 9.3 millimole per liter. So the key is here, or the tip is here, if you see a very wide Corus complexes of more than one big box, more than 0.20 second, hold yourself. Think about the other causes of wide complex tachycardia. Think about the toxicology, especially tricyclic antidepressants. Think about the electrolytes, hyperkalemia. Okay, so just change your management and give the patient calcium and bicarb first, then antiarrhythmics. Giving calcium and bicarb is not going to harm the patient, not at all, but it may save the life of your patient. But in routine clinical practice, the top 10 causes of wide complex tachycardia are ventricular tachycardia, ventricular tachycardia, ventricular tachycardia, ventricular tachycardia, and up to 8 number, it's VT. VT, 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 VT. And then the ninth cause is SVT with aberrant conduction or pre-excitation syndrome. And in the last, there are a few more causes of wide complex tachycardia. That's electrolyte disturbances, hyperkalemia, sodium channel blockage because of tricyclic antidepressants, overdosage, or paced rhythms. The pearl is that the most of the wide complex tachycardia is ventricle in origin, or ventricular tachycardias 80% of the time. But sometimes it's very important to keep yourself vigilant and take the history, especially the renal disease, toxic overdosage, and check the potassium level in stable patients if you are in doubt, and try to seek the expert opinion if the time permits. Thank you very much. And now let's proceed to the module 2, which will be the last module of our advanced ECG course. Whatever we have learned in the first 3 modules, we are going to apply in an extensive exercise which is called putting it all together.